Mr. Chairman, ladies and gentlemen, good morning. I'd like to thank the organizers for giving me the opportunity to review the current status in anticoagulant therapy in patients with established venous thromboembolism. Here are my disclaimers. As a kind of a background I will use the term venous thromboembolism because most people believe that we're talking about a single disease here with two manifestations and occurring at the same time very often. So when I refer to venous thromboembolism, I actually refer to deep vein thrombosis and pulmonary embolism together. That disease actually has an annual incidence of about 2 to 3 confirmed cases per 1,000 inhabitants, and thereby it actually is the third most common vascular disease after myocardial infarction and stroke. There is even indications that the incidence of venous thromboembolism is gradually increasing rather than decreasing, which we see with some of those other vascular diseases. And the final point here in terms of the annual incidence is that we now have evidence from different parts of the world that this frequency also is applicable to North America, South America, Europe, and Southeast Asia. What I will try to do in my review is focus on the usual treatment of venous thromboembolism. And what I mean with that is we do know that less than 1% of patients that present with symptomatic venous thromboembolism have a massive episode of venous thromboembolism, which usually needs treatment with either thrombolytic therapy or even surgery. I will not talk about that one. The minimal venous thromboembolism is we're well aware in our diagnostic. If the ultrasound of the upper part of the leg is normal and there might be a small clot in the calves, we will ignore that because the natural history of that type of clot of minimal disease actually is quite favorable, and probably the same is true for the lungs, and therefore no treatment is usually given. The great majority, however, of patients will actually receive anticoagulants. And what I would like to outline in the next 20 minutes is actually it took us 70 years from the first use of unfractionated heparin in patients to 2008 to understand and to do the studies to make the current treatment of low molecular weight heparin followed by vitamin K in a proper way. It took us 70 years to find out how we should use low molecular weight heparin and heparin before that and vitamin K. What I will also illustrate is that the first study with the new oral agents or the subcutaneous new agents, the first actually was published in 2009, and my prediction is that the last one of the ones which I will review with you in the next few minutes will actually be ready in 2013. So what we need to understand is the contrast between 70 years of evaluation is now actually, with the attention to this disease and with the large number of investigators around the world, is now condensed to about 4 years. And that will have major consequences for your and my practice. I will finish with some few remarks about what the future will bring. This is what I illustrated here. The very first use of heparin, actually, as you can see, was a cohort study in 35 patients published by Murray and Best in 1938. Quite interesting to see that in those days, mortality was the outcome. Clearly, the well-known study by Barrett and Jordan in the 1960s and all these others in between was probably the turning point in our perception that patients with venous thromboembolism need anticoagulant treatment, because as you all know, Barrett and Jordan only needed 35 patients in a randomized trial to see that no treatment was really terrible. In the subsequent period, between, as I say, a year between 1972 and 2005, we start to understand what the appropriate monitoring would be, the use and the introduction of the INR concept for vitamin K antagonist, how long we should initially treat, as well as the introduction of low molecular weight heparins, which would facilitate out-of-hospital treatment. And this is nicely summarized, and this brings me from 1938 to 2008 in the most recent authoritative review of Clive Kieran and colleagues in CHEST, where they basically come up with this schedule that for initial treatment, we have a few options, as you can appreciate. But as soon as we get, this is for the first 5 to 10 days, but as soon as we get out to either long treatment or even a much longer treatment, we're actually talking about 2 drugs and basically about 1 drug, which is vitamin K antagonist. And low molecular weight heparin, as probably also most of you know, is the one which is used in long-term treatment in patients with venous thromboembolism and cancer. And this is exactly what we have all the way up to 2008. And here's my favorite slide, because it illustrates that all our investments in trying to understand the coagulation system down to the molecular level has at the same time generated a great insight in possibilities of new anticoagulants. And I'm not going to discuss all of those, but we now can group them as the ones that interfere with initiation, that interfere with tissue factor 7A complex, or one of the components there. The other one where is a lot of activity, which you will appreciate from the number of drugs that are here, while this list is far from complete, is the inhibition of 10A. Then here, the oldest one with Hirodin and Agatoban, but probably most important for today's discussion is going to be Dabigatran. At this conference, there are actually some very intriguing reports about other ones which are here that interfere with either factor 8 or factor 11 or other parts in the amplification loop. And my prediction is that these new anticoagulants actually will also come to the clinical arena and need to be appreciated in the choices we make in the treatment of patients. What I'd like to do in the next 7 or 8 minutes is quickly go through that evidence that indeed started in 2009 and that was added even this morning with 2 new presentations in the late-breaking session at 8 o'clock this morning. So we'll take what the evidence is in each of these different sets of clinical studies. This is the picture of the 5 sugars that actually bind to antithrombin, and that's the reason why it's called the penta. Penta is 5 in Greek, is the 5 sugars. Now the only difference here is that for the biotinylated Idraparinux, what I will talk about, is that this biotin was added here with a spacer. And the reason to do that is actually that we do know that the biotinylated part allows neutralization by avidine, which is well known, an extract from white part of eggs, and that will neutralize its effect directly. Now, the first study I'm going to share with you is actually published in this year, early this year. And this was a randomized double-blind trial where Idraparinux, which was the parent compound, the mother compound, so to say, was compared to Idraparinux. Why was this done? Because Idraparinux is being studied in the Van Gogh DVT study, which was a large 3,000 patient study, and showed to be equivalent in terms of efficacy and safety to the standard treatment of low molecular weight heparin and vitamin K. So in this study, we asked the question, is this new Idrabio, is that equivalent in biotechnical terms? But we also had the opportunity to follow these patients in this double-blind trial for clinical outcomes. And let me just share those ones with you. Because as you can see here, in the Idraparinux, which we would take as the reference here, had a recurrence frequency over 6 months of about 3%. And this figure you will see over and over again, because that is the frequency we also see with low molecular weight heparin and vitamin K antagonist. And the Idrabio in this moderate-sized study actually was associated, as you can see, with a frequency of recurrence of 2.3%. And if you look at the absolute difference in favor of Idrabio, clearly is not significant. That was not powered. But there's a very clear message that it is at least as good as Idraparinux. What about safety? The safety is here, as you can see, 7% any bleeding. Here's major bleeding with the comparator, so to speak, and favorable data suggestive of actually a decrease in the frequency of bleeding with Idraparinux. Let me now turn to this study, which again was presented this morning at the late-breaking session, has not been published, is about to be published by The Lancet. In this study, patients received Idraparinux for either 6 months or 3 months after an initial course of 5 to 10 days of low molecular weight heparin, or they received warfarin for 6 months or for 3 months. One interesting and important fact to realize is that all these patients were followed for an additional period of 3 to 6 months. The dose of Idraparinux was 3 milligrams, which is identical to the bioequipotent dose of what was used with Idraparinux. Here are the baseline data, almost 1,600 or 1,600 patients in both arms. One thing to point out, very often people think that pulmonary embolism is a disease of old age. Here you can appreciate that the mean age actually is 57 and 58 respectively. Here is the primary outcome at 3 months for efficacy. Let's take you through the numbers. Warfarin, 2.7%, very close to the 3% we talked about, and actually 2.1%. If you do the calculation, the odds ratio of 0.79, and here's the confidence interval, really clearly making the assumptions we had about non-inferiority. So very clearly non-inferior in terms of efficacy. This is 3 months for both strata. 80% of these patients actually were treated for 6 months. And that is what you can see here. If we moved out all the way to 6 months, the hazard ratio here now in the Kaplan-Meier, as you can see, is 0.77, very consistent with what we observed at the 3 months point. So still clearly non-inferior. What about safety? At 3 months, we already observed this signal earlier. But what you can see here, and at least in my experience, is the very first drug that actually is associated with non-inferiority, but on the other hand, it is safer than what we have today. And that, as you can appreciate here, is a rate of treatment of bleeding at 3 months of 6.6, 4.5, which actually is a reduction of 33%, and it's highly statistically significant. Now, as I mentioned, these patients were, the great majority, 80% of these patients were actually treated for 6 months. So the question is, what happened over time? And this is here. If you now look at 6 months period, the hazard ratio is very similar. It's a 30% reduction and still statistically significant. And this is a once-a-week subcutaneous injection. But here's the most pleasant surprise, dear colleagues, because now these patients stop treatment, at least the great majority of these patients stop treatment. And we follow those patients now for an additional 180 days. And what you observe here in the vitamin K recipients is that almost immediately from the time you stop vitamin K, we start to see recurrences. And I'll show you another piece of data in a second, which confirms that in another study. However, in the ones that had been treated with Idraparinux, there was actually a continued protection. Now, the obvious question is there any difference in terms of bleeding? And the answer is no. Is there an additional risk of bleeding? This is the end of treatment. And here what you can see, this is in the group of patients that had stopped treatment. I forgot to mention that about 15 to 20% of these patients were switched to warfarin. 85% of these patients were stopped treatment. And actually what you do see here is the bleeding associated with that anticoagulant treatment in most cases. So therefore, I think today, for the first time, when we look at these two studies together, we have a quite good and attractive alternative of a simple single injection once a week. Let me then just go quickly to Dabigatran etixylate, which actually was the first to come out with a study in the treatment of venous thromboembolism. And my dear friend Sam Schulman and his colleagues actually performed this study. And this is where the 209 experience started. And this is the RECOVER study, most of you know, is a randomized double-blind study comparing Dabigatran versus vitamin K. All these patients initially received low molecular weight heparin. And the outcome is here and published, is the 2.1 in warfarin, slightly lower to what we've seen in some of the other studies where it's closer to 3. But nevertheless, it's a randomized comparison and internally consistent. And in Dabigatran, a very similar figure. That's the absolute difference and the 95 confidence interval of that observed difference. What about bleeding? Here you can see 8.8 over the 6 months period and 5.6 in the Dabigatran recipients, a suggestion of being slightly lower. As I mentioned this morning, the late-breaking session, Sam Schulman and colleagues presented the RESONATE study, and the RESONATE study asked the question that if I have treated for 6 to 18 months, which most of the physicians in this audience would consider a period to see whether you need to stop the treatment. Of course, in patients with cancer or high-risk patients, you would continue. But in the great majority of patients, there would be a time where you would consider stopping. And what they did is they randomized these patients to placebo or Dabigatran, basically continued the Dabigatran in some of these patients. And what you can see is a huge difference here. This is in the placebo arm over about 6 months. The recurrence frequency is 6%, 1% per month. While in those that got Dabigatran was 0.4%, a huge reduction of 80 or 92%. Is there a price to pay? Actually, that's quite modest, because you can see there were 2 episodes of major bleeding, 0.4%. There were no bleeding in placebo. But I think if you look here, this is over the 6 months period, the number of clinically relevant bleedings, which is a combination of major and clinically relevant non-major, actually occurs in 2% of patients on placebo. So that's the background noise. And what you do see here is in the Dabigatran, it's about 3% higher. What is still to come? The RECOVER-2, which actually included around 3,000 patients in patients with venous thromboembolism, will be coming soon, probably in the next couple of 6 to 8 months. Let me now switch at the end to Rivaroxaban and quickly take you through the evidence we have there. This is Rivaroxaban, and this is the background information. But the clinical studies actually come in 3 studies. One is the deep vein thrombosis, called the Einstein deep vein thrombosis, the Einstein pulmonary embolism. And here's a very similar study to the one I just presented to you. These were patients that were treated for 6 to 12 months and then compared Rivaroxaban with placebo. The pulmonary embolism study I'll talk about later, but the deep vein thrombosis study, the difference here is that Rivaroxaban was used right from the start without low molecular weight heparin in a slightly higher dose of 15 milligram BID all the way up to 20 milligram. And this was compared to the standard of low molecular weight heparin followed by vitamin K. And here is the Einstein DVT data, both in absolute terms, as you can see here, the recurrence frequency of over about 6 months is 3%. Where have we seen that figure before? And what you can appreciate here is that with Rivaroxaban numerically go down from 51 patients to 36, which actually is 2.1%. And we exactly do the same thing as was done here, albeit with a hazard ratio of 0.68. And this is almost statistically significant, but our objective was to show non-inferiority, which was clearly met. What about the other side of the coin, which is bleeding? 8.1%, 8.1%, actually 20 major bleeds over 14 major bleeds in the Rivaroxaban. The Einstein extension, which now actually can be compared to the RESONATE, actually shows very, very similar results, because this is at the end of 6 to 12 months of treatment. Here is what you see if you get placebo, and this is actually what you see if you continue to give Rivaroxaban in these patients. The reduction is 82%, and quite impressive. The number needed to treat is actually 15%. There are not many treatments that are so effective in terms of number needed to treat. I'll have to share with you, of course, the bleeding, which is here, and is the combined here of major bleeding and clinically relevant, which again is 1.2% in the placebo and 6%, so a difference of about 4 to 5%. What is still to come, as I mentioned, the Einstein pulmonary embolism has included a total of 4,840 patients. That was an event-driven study, and that study has completed recruitment, and we are about to complete the follow-up, and the data will be available in 2012. This is not the only one. I have reviewed the ones for which we have phase 3 clinical evidence, but very soon the data from Amplify and Amplify Extension. Amplify Extension actually has completed recruitment and is in the phase of follow-up. Amplify will hopefully finish also very soon. Another very large program of about 7,500 patients is the HOXI study with Rivaroxaban. So, Mr. Chairman, ladies and gentlemen, let me go to my conclusions. We need to be prepared ourselves as well as our colleagues for a major shift in the treatment of venous thromboembolism. And I think if there is one message I'd like to give you when you leave this room, there is no time to ignore these developments. They are going to be on your doorstep almost next week or next month. And we need to prepare for the many questions that will come with these new drugs. I mentioned that we took 70 years to understand how to use heparin and low-molecular weight heparin vitamin K. We produced studies with the new anticoagulants in 4 years' time. But we need to prepare, as I mentioned ourselves, on how we need to help physicians to use this drug. Please give me one more minute to look into the future, because I think the future is bright. And what I would like to do is just touch on one particular aspect of new therapeutic avenues, and I'll show you a couple of other ones. I'm going to share with you another unpublished data that was generated at the Academic Medical Center by Peter Willem Kamphuis and Sarah Rafi. And what they did is they looked in a very large database of a large number of patients that had an episode of pulmonary embolism, and then followed these patients, as you can see, for quite some time. And these are the patients that were treated with anticoagulants, but did not receive statins. And here you see in green is the patients that actually received statins, of course, for cardiac reasons. And what was the astonishing observation here is that actually the use of statins, and this is all uses, short periods, long periods, different intensities, the reduction was 52% in the recurrent venous thrombosis. There actually was a reduction in total mortality. And this, of course, was corrected in this type of retrospective analysis for some of the expected confounders. I think a real invitation to study this particular new drug. And so this is my last slide, Mr. Chairman, ladies and gentlemen. I think we need to pay attention to the statins because we have these new anticoagulants. They're beautiful. They are easier to use, but they do not lower the rate of recurrences. And we need to do a better job. And probably we also have to evaluate, we'll have data very soon from Giancarlo Angelian from Australia about the use of antiplatelets after a period of anticoagulant treatment. And finally, as we now see in the arterial field, are drugs that interfere with the vessel wall integrity, whatever that means. But we're very interesting new compounds that probably are going to be helpful in further reducing this risk of recurrence, which still is quite substantial, 25 to 30% over a period of about 5 to 7 years. What are the challenges with all these new beautiful things? Is no, we cannot monitor, and we have to develop strategies for measuring adherence. We have to develop information booklets for our colleagues and patients on how to deal with all these well-known questions of bleeding, bridging, etc. And finally, we need to do a better job on who should receive prolonged therapy, and that's the issue of duration of therapy. Let me just finish, ladies and gentlemen, by thanking the authors for the state-of-the-art contribution, Josien van Es, Elise Ehrenberg, and Peter Willem Kamphuis, and my very distinguished colleagues at the Academic Medical Center for their continuous support. Thanks for your attention.